Good afternoon, ladies and gentlemen. It's my pleasure to give a talk about 4D imaging and online motion management. My name is Antje Knopf, and I currently work at the University Klinikum in Cologne. I have nothing to disclose, but I would like to emphasize that most of the work that I will be talking about was done during my time at UMCG in Groningen. I would like to start this talk with setting the stage of a current survey that is conducted about the pattern of practice for adaptive and real-time particle therapy. This is based on work that has been published in the recent years in the photon world and is now repeated in the proton world to determine the status of adaptive particle therapy and real-time respiratory motion management, how it is implemented in the particle world nowadays. This work or the results of this survey for Europe are also presented in 2 talks here at the ESTRO, and I just want to mention some key results to set the stage. So this survey, we had a response rate of over 90% for particle centers in Europe and Japan, and over 50% for particle centers in the US. In terms of Europe, all the centers that are answered to the survey are equipped with pencil beam scanning, and about 70% of them are treating moving targets. In terms of how they do that, real-time respiratory motion management is currently clinically applied in about 70% of these centers. So that means they use gating or press hold or some combinations of gating and press hold together with rescanning. And the remaining 31% that don't use yet real-time respiratory motion management plan to do it in the future. So there is a significant interest reported to implement these active real-time respiratory motion management techniques in the future. And we asked what are at the moment the barriers for implementing that. And it was reported that mainly technical limitations, limitations in the equipment or human resources currently hinder the implementation of a wider range of real-time respiratory motion management. So one can basically state that real-time respiratory motion management is getting more and more adapted in clinical practice with a lot of potential for further development in the particle world. So maybe let's go one step back and remind ourselves what are the challenges when treating moving targets with particles. So as we heard, most of the centers are equipped with pencil beam scanning that enables basically a very conformal treatment of targets. However, if you treat moving targets with pencil beam scanning, then you have to deal with the interplay effect, which is basically the interference of the delivery timeline with the timeline of the motion of the target. And that can result in inhomogeneous target doses. So that was basically one of the main concerns or is still a main concern when treating moving targets with pencil beam scanning. Furthermore, we also know that motion can be very variable. This graph shows for 40 patients the extent of motion in the planning CT compared to the weekly extent of the motion in the weekly repeated 40 CTs. And you can see that there can be a large variety. It can be that the planning CT maybe only shows 3 millimeters target motion, but then throughout the treatment that can easily double or even triple. And another challenge is that especially when treating, for example, lung tumors, we can see a fast regression in these tumors. So within the fractionation scheme, the anatomy of the tumor and the surrounding tissue can change. Which is a problem for protons because they are highly sensitive to density changes. And of course, also inconsistencies in the patient setup can challenge the dose distribution. So in summary, this interplay effect, varying motion and anatomical changes basically can lead to dosimetric uncertainties when delivering these doses. I would like to now, in a little bit more detail, show what over the last years has been implemented at the Particle or Proton Center in Groningen in terms of motion management for lung and thoracic tumors. So for that, I'm showing here a floor plan to emphasize again that this workflow is basically enabled by having the possibility to a lot of data when treating these patients. So within the gantry room, we in Groningen had the possibility to record the online motion via the ANSI belt, and also we had access to the delivery log files. In addition, we see that close to the gantry rooms, there is the possibility for taking weekly repeated 4D CTs. So this information in combination enable the workflow for 4D dose reconstruction and accumulation. So what did we do? With this online ANSI motion record and the synchronized or the synchronized delivery log file information, we basically could determine what part of the dose was given to which breathing phase. And we could basically order the dose contributions to each of the 4D CT phases. And then afterwards, we can warp back these sub-contributions to a reference phase, and in that way, basically have an idea of the actual delivered dose, including the interplay effect. So here you can see as an example how these phase by phase dose distribution look like. You see basically in each phase a part of the dose is given, and if this is summed up and warped back to a reference phase, then as I said, it gives you a pretty good idea of the actual delivered fraction dose considering the interplay effect. So what can we do with this information? So if we do that day by day, we basically can accumulate these reconstructed doses, and we can determine what is our limitations for accepting if these accumulated doses basically leave some kind of boundary in terms of the prescribed dose. If that then happens, then we can trigger an adaptation, and with this adaptation we can then get back to the planned dose that was determined in the planning phase. Here are some preliminary clinical results that also have been published, and basically for one Hodgkin lymphoma patient and one lung patient. What you can see here is color-coded the DVH of the target for all the fraction doses. So on the right side, it's a little bit more clear. The color code basically determines DVHs in the same color are reconstructed on the same weekly CT. And then if you accumulate these doses, you basically end up with a black line, which is basically the delivered dose for the whole fractionated treatment. And for the lung patient on the right side, you can see that there is some variety. Basically, on each day, these fraction doses can vary a little bit, but then overall, if you accumulate them, they pretty much are matching what was prescribed. For the Hodgkin lymphoma patient on the other side, you see that this spread in the weekly or in the daily reconstructed doses is pretty small. So from this preliminary clinical results, we saw that the fraction-wise loss of target dose homogeneity due to the interplay effect and organ motion showed no systematic pattern and smeared out with the fractionation. And contrary to findings in simulation studies, clinical 4D dose monitoring did not observe any relevant loss of target dose homogeneity due to the interplay effect or motion effects. and the dose degradation that we saw was mainly caused by anatomical changes that showed to be more severe than the interplay effect. So now I would like to go a little bit into the current limitations in this workflow still. So as I said, these dose reconstructions currently are done on weekly repeated 40 CTs. Of course, there is then still some assumption that these weekly repeated 40 CTs are representative on a daily basis. It would be, of course, even nicer if we would have daily anatomical information. And here I'm pointing to a work that is also presented at the ESTRO, where based on 40 CBCT images, synthetic CT images are constructed in order to have this daily anatomical information. And with the help of AI and machine learning, we nowadays actually can get quite high quality images that seem to be suitable also for proton dose calculations. Another current limitation is that we are considering basically the motion being some periodically repeated variation, while we know that in reality the motion is not completely equal in terms of phase and also in terms of amplitude. So this could be overcome by combining basically initial 4D imaging data on which you can construct some kind of motion model, which can then be fed by a daily surrogate motion that is basically reapplied to this motion model, and in that way consider a time resolved motion that is varying in phase and amplitude. This idea has been published by the group in Switzerland at PSI, and would be a way to overcome this limitation. And finally, this approach highly is based on dose warping. There is in the literature a lot of mentioning that the form of the images registration on which this dose warping is based on has some limitations by itself as well. And I think there is still work needed to basically improve and validate these dose warping algorithms. So with this, I hope that I could show you that 4D treatment planning and 4D dose reconstruction and accumulation can enable a safe and efficient proton therapy treatment for thoracic indication. And this workflow is based on monitoring the motion, ideally on a daily basis, and could actually pave the way also for real-time adaptive proton therapy. And to end this talk, of just a few words on the real-time adaptive proton therapy. There has been a consortium very active in the recent years, which is the Raptor consortium, that secured money for a European training network that hired at the beginning of this year 15 PhD students that will basically work on further or getting real-time adaptive proton therapy closer to the clinic in the future. It's an international consortium comprised of clinical, academical, and industrial partners. And the goal is basically, as we already saw in this first slides, that there is a big appetite to go into this direction, but it's mostly still hindered by manual, time-expensive workflows and human resources that are limited. So this Raptor consortium strives to enable like a paradigm shift to get away from this manual stepwise approach towards a more automated, seamless workflow, integrating imaging, treatment planning, and quality assurance into a kind of real-time adaptive particle therapy treatment loop that is depicted here. And with this, I would like to thank you very much for your attention. And I also would like to acknowledge people that contributed to this work, mainly people from UMCG, the people that are conducting the pop art PT survey, and also the project coordinator from the Raptor ETN program. Thank you very much.
Thank you very much for this very interesting and important work you presented to us. I was wondering, you mentioned that inhomogeneous breathing might be a challenge. You have a change in frequency and amplitude, and you mentioned a few ways to overcome that. But you didn't mention the possibility of coaching the patient, either visually or with sound. Can you comment on that? I thought that would be a good way to minimize changes.
Yeah, indeed. Actually, another way how you could deal with that problem is to try to somehow regulate the motion. And for example, in Groningen, we also looked into the possibility of mechanical ventilation. That's also a way to basically try to make the breathing more regular. However, I also see that some studies show that not all patients tolerate that. So yeah, I mean, I only pointed out to this way how to model it, but of course you are right. Another way would be to regulate it.
Okay, thank you. We also have a question from the audience that reads like this. Do you take the accumulated 4D reconstructed dose into account as background dose during plan adaptation in the clinical workflow?
No, we don't do that yet because, to be honest, there are still some limitations. So as I also try to point out in the talk, it is an estimate and there are, of course, also uncertainties in this dose reconstruction. So I think it's too early now to also base then basically further dose calculation on this uncertain reconstructed dose.
Okay, thank you. Do we have any questions from the room, Petra?
Yes, we have one question here in the room.
Yeah. Hello, I'm Carlos from Spain, University of Navarra. Thank you very much for your talk, really nice presentation. I saw one slide when you said something like we should taking into account the accuracy of the dose accumulation method and most of the deformable image registration algorithm. When you are going to do that process, we don't include the energy per mass conservation in that process. So there were many studies that they checked it with photons, and they found several differences. So do you consider to include this kind of characteristics in your methodology in order to take into account the effect of those characteristics in the proton therapy?
Thank you for this question. I think it's definitely a thing one should look into. I personally didn't research on it yet myself. I mean, we looked into what are the uncertainties if using different deformable image registrations in general. But you are right, that is something we should look into. And within this Raptor, there is actually also one PhD project that is specifically looking into dose accumulation and how to improve that.
Yeah, because maybe if you have a lot of fractions, maybe it can be a concern because if the organ change a lot, maybe it can be a question. But for SBRT treatment, for example, in a few fractions, maybe to quantify the dose in the organs, maybe we should consider to include this kind of stuff because maybe the effect with proton is higher than with photons. So in order to have a more realistic dose, right?
Yeah, definitely.
Okay, thank you very much.